Imagine an elderly man uh, rolling into your department. He's writhing in pain, clutching his lower back and his flank.
Oh, yeah. Classic.
Right, his blood pressure is steadily dropping, and the triage nurse hands you the chart and notes that he looks exactly like a standard kidney stone case.
Right.
But if you just blindly treat him for a kidney stone without, asking a very specific set of questions, there's a 30% chance you are about to make a fatal mistake.
Yeah, and about a third of those presentations, that intense flank pain is, well, it's definitely not a passing stone. It's a ruptured abdominal aortic aneurysm.
Wow.
Yeah. And the difference between the two is literally a matter of minutes. Catching it relies completely on how you, the evaluating physician, process the information right in front of you.
Well, we are diving straight into the deep end today. Welcome to a high-yield clinical deep dive. We're acting as your virtual medical educators, and we're taking you through a rapid-fire ED rotation.
And this is all based strictly on the USMLE Roadmap Emergency Medicine
Mm.
by Dr. Scott C. Sherman and Dr. Joseph M. Weber.
Exactly. Our mission here is to just bypass the dense textbook fluff and extract the precise what, why, and how of these emergency presentations.
Because the goal is to train your clinical brain to prioritize life-threatening conditions immediately.
Okay, let's unpack this, because stepping into the emergency department requires a massive shift in your cognitive framework, doesn't it?
Oh, absolutely. I mean, the rest of the hospital operates kind of like a funnel. They gather exhaustive data, run countless labs, and slowly narrow everything down to one definitive diagnosis.
Right, but the ED is different.
Yeah, the ED operates like a filter.
Hmm.
Your immediate job isn't necessarily naming the exact disease in the first 5 minutes.
Okay.
Your job is to aggressively filter out the specific things that will kill the patient in the next 10 minutes.
Right, the filter mindset. Okay, let's structure this deep dive around that. We're going to move from localized tactile procedures, then zoom out to systemic crashing traumas, and then navigate internal vascular emergencies.
And then cap it off with some highly specific genitourinary and neurological do-not-miss diagnoses.
Sounds like a plan. So starting at the procedural level, that really gives us a great window into that clinical problem solving, like take incision and drainage.
Right, I&D fluid removal.
Yeah, so you're evaluating a swollen, red, tender area of skin. The crucial physical exam finding you are hunting for is fluctuance.
Exactly. When you press on the tissue, it feels like a water balloon under the skin,
Right.
which mechanically distinguishes a true abscess, a pocket of trapped pus, from a broader, more diffuse cellulitis, which is just infection in the skin tissue itself.
Right, and the textbook points out risk factors for these pockets of purulence. We see spikes in the summer months, but the big systemic red flags are IV drug use, poor hygiene, minor trauma, and immunocompromised states.
Yeah, definitely.
But when it comes time to actually drain it, the mechanics of how you apply local anesthesia really matter. I mean, if I picture that pressurized water balloon, taking a syringe of 1% lidocaine and injecting it directly into the cavity.
Oh no, that's a terrible idea.
Right. See, it
Yeah.
seems so counterproductive. You're just pumping more volume into an already stretched, agonizingly tight space.
Yeah, doing that causes excruciating pain. And you risk, blowing the roof off the abscess entirely.
Wow.
The proper technique is to prep with povidone iodine and carefully numb the skin around and over the roof of the abscess.
Okay.
You utilize the subcutaneous tissue layers without ever piercing the main cavity. Only after that perimeter is numb do you take your 11-blade scalpel and make the incision.
That makes total sense.
Hmm.
But clinical medicine is full of exceptions, right? Like not every abscess gets that standard wide slice and packing tape.
Right, anatomical location changes everything, like pilonidal abscesses.
Oh, yeah. The ones in the sacrococcygeal area, just above the gluteal cleft. The text notes that if you just numb and drain those in the ED, there's an 85% recurrence rate.
It's massively high.
Yeah, because the anatomy there is just so prone to trapping hair, sweat, and debris deep in the tissue tracts. They almost always require definitive surgical excision in an OR to actually cure the underlying problem.
Exactly. And another major anatomical exception involves Bartholin's gland abscesses.
Oh.
Yeah, these glands sit just inside the vaginal introitus, providing moisture. When they get blocked and infected, a wide incision with iodoform gauze packing is just the wrong move.
Because mucosal tissue doesn't heal well with rough packing.
Right, the gland will likely just seal right over and block again.
So the text recommends a tiny half-centimeter incision and inserting a word catheter, which makes sense mechanically. Instead of packing the wound open, you insert this tiny balloon catheter, inflate it with saline, and leave it in for several weeks.
Yeah, you're forcing the body's tissue to heal around the catheter stem.
So it forms a permanent epithelialized fistula tract. You're essentially building a brand new drain pipe for the gland.
It's a highly testable, immensely practical clinical pearl. Now, shifting from removing purulent fluid to extracting high-pressure blood.
Ah, the arterial blood gas.
Right, the ABG. It's a daily procedure. We need precise partial pressures of oxygen, CO2, and the blood's true pH.
Okay, so you locate the radial artery in the wrist. You extend the wrist about 30 degrees over a rolled towel to bring the artery closer to the surface and go in at a 30 to 45 degree angle.
Exactly. But the text strongly advises raising a 1% lidocaine skin wheel before you do the actual ABG needle poke.
You know, I have to push back on this a bit based on practical workflow.
Oh, how so?
Well, you're doing a needle poke to numb the skin for another needle poke. I'd imagine poking the area first might cause the artery to spasm,
Yeah.
messing up your success rate for actually hitting the vessel.
You'd think so, but the underlying physiology of arterial spasm actually works in favor of the lidocaine.
Wait, really?
Yeah. The artery spasms due to the severe, deep pain of the ABG needle, which is much thicker and digs far deeper than a tiny insulin syringe used for the skin wheel.
Oh, I see.
Raising that wheel significantly decreases the deep pain response, which actively prevents that pain-induced arterial spasm. And clinical studies confirm it absolutely does not lower your success rate.
Okay, that makes sense. And the biggest warning the book gives for ABGs involves the redirect, right?
Oh, yeah. This is critical.
If you miss the artery on the first pass, you must withdraw the needle to just below the skin surface before changing your angle.
Right. If you try to sweep the needle side to side while it's deep in the tissue.
That sharp bevel acts like a tiny scalpel blade.
Exactly.
You will lacerate the radial artery, turning a simple diagnostic test into a localized hematoma.
And a potential vascular emergency, which bridges us perfectly from a localized vascular puncture to system-wide vascular collapse.
The crashing trauma patient.
Right. If we connect this to the bigger picture, trauma care is rigidly, aggressively systematic. You don't get to be creative.
It's all about the primary survey, the ABCDEs.
Airway, breathing, circulation, disability, exposure.
We hear it so often it sounds like a nursery rhyme, but the physiological logic is absolute. You cannot move to B if A is compromised.
Right. There is 0 point in listening to the lungs to see if nair is exchanging, if the physical pipe, the airway, is crushed or blocked.
So you fix the pipe, maintaining cervical spine alignment before you even pick up your stethoscope.
Exactly. And when you get to disability, you're running a rapid neurological filter.
Like calculating the Glasgow Coma Scale, the GCS, to quantify consciousness.
Yeah, and checking for asymmetric pupils to see if the brain is actively herniating from built-up pressure. But E-exposure is where the physiological cascades get really interesting.
You completely undress the patient, right? You have to physically look in the armpits, the perineum, the back for hidden penetrating trauma.
Right. But the second half of E is just as vital, immediately covering them back up with warm blankets.
The text emphasizes that hypothermia in a trauma patient isn't just an issue of comfort. It's a life-threatening physiological derangement.
Because as the core body temperature drops, the enzymatic reactions that drive the body's clotting cascade just stop working.
Wow. The blood literally refuses to clot.
Yeah. The patient develops a profound coagulopathy. If they're cold, they will bleed out from injuries that would otherwise naturally clot off.
And speaking of bleeding out, the text provides a brutal but brilliant clinical rule for the trauma bay. Hypotension in the trauma patient is attributed to hemorrhage, hemorrhage, and hemorrhage.
Only then are other etiologies considered. The tank is leaking until proven otherwise.
Right. And sometimes that leak is obvious, like a compound femur fracture, but sometimes it's hiding in the abdomen, which brings up Kier's sign.
A classic physical exam finding.
Yeah. A patient complains of intense left shoulder pain, but you palpate the shoulder, move the arm around, and there's no local tenderness or mechanical issue with the joint whatsoever.
Because the shoulder is structurally fine, the pain's referred via the phrenic nerve.
Okay, break that down for us.
Sure, so that nerve innervates the diaphragm, but it shares a nerve root pathway in the cervical spine with the sensory nerves of the shoulder.
Right.
When you have a massive spleen laceration, free blood pools underneath the diaphragm, chemically irritating the phrenic nerve, the brain just misinterprets that diaphragmatic irritation as shoulder pain.
The wiring of the body acting as an alarm system for hidden internal bleeding, that's fascinating.
Now, if that hemorrhage progresses, or if an underlying medical issue pushes the patient into a full cardiopulmonary arrest, we often encounter pulseless electrical activity, PEA.
Right, the monitor shows an organized heart rhythm, but there is no pulse. The heart muscle isn't pumping. The text gives us the 5 H's and 5 T's as the mental filter here.
And rather than just listing them, let's look at the mechanics of why these specific conditions stop the heart from generating a pulse, even when the electrical system is still firing.
Okay, so the H's are hypovolemia, hypoxia, hydrogen ion, which is severe acidosis, hypothermia, and hyperkalemia.
Right, hypovolemia makes complete mechanical sense.
The electrical pacemaker fires, the heart muscle squeezes, but the tank is completely empty from massive bleeding.
Exactly. There's no fluid to pump, so no pulse.
And severe acidosis, the hydrogen ion, functions similarly to hypothermia.
Yeah. The blood pH drops so low that the cellular machinery and calcium channels required for the heart muscle to physically contract just denature and fail.
The signal arrives, but the muscle ignores it.
Right. And hyperkalemia, excessive potassium, destroys the resting membrane potential of the cardiac cells, preventing the electrical signal from propagating correctly.
Okay, then you have the T's. Tablets meaning a massive drug overdose. Tamponade, tension pneumothorax, thrombosis pulmonary, and thrombosis coronary.
Let's look at tension pneumothorax. Air gets trapped in the chest cavity, building massive pressure.
It physically pushes the lungs over, crushing the thin-walled superior and inferior vena cava.
Right. So blood physically cannot return to the heart. The electrical signal fires, but preload is zero.
And cardiac tamponade does the exact same thing from a different angle. The pericardial sac fills with fluid, crushing the heart from the outside so the chambers can't expand to fill with blood.
Exactly. Running that 5 H's and 5 T's list isn't just an academic exercise. It's hunting for the mechanical blockage you need to reverse, whether that's decompressing the chest with a needle or aggressively pushing IV fluids.
Makes perfect sense. Okay, having filtered through Blint trauma and arrest, we transition to internal time bombs.
The vascular emergencies.
Right. These present as severe pain or altered mental status in patients who might look perfectly stable in the waiting room but are actively crashing on a cellular level. Let's look at hypertensive emergencies.
So, to manage a hypertensive crisis, you have to calculate the mean arterial pressure, or MAP, right at the bedside.
The formula in the text is 1/3 of the systolic blood pressure plus 2/3 of the diastolic.
And the mechanical reasoning here is based on the cardiac cycle. The heart spends about 1/3 of its time actively squeezing systole and twice as long relaxing and filling diastole.
So your average pressure across the whole cycle heavily favors that resting diastolic pressure.
Precisely. And you use that MAP target to distinguish between two conditions that look identical on arrival: hypertensive encephalopathy and an ischemic stroke.
Both patients present with severely elevated blood pressure, altered mental status, focal neurologic deficits.
And most importantly, both will have a completely normal, clean, non-contrast head CT scan.
Right. The scanner tells you nothing about the underlying cause.
So you're flying blind with imaging. You have to use your intervention as a diagnostic test.
The text suggests carefully layering the MAP by 25% over a 30-minute period.
Right. If the patient has hypertensive encephalopathy, the brain was just mechanically swelling against the massive vascular pressure.
So as you lower the pressure, the brain perfusion normalizes, and the neurologic symptoms physically start to clear up right in front of you.
Exactly. But if it is an ischemic stroke, lowering the blood pressure will have zero effect on the neurologic deficits.
Because the issue isn't overall pressure, it's a localized clot-blocking flow to a specific brain region.
Right. In fact, dropping the pressure too fast in a stroke can worsen the ischemia by starving the peripheral brain tissue, which is why that 25% reduction must be strictly controlled.
Here's where the filter gets really ruthless. Let's circle back to our intro scenario. Aortic dissection versus a ruptured abdominal aortic aneurysm, or AAA.
Oh, right.
The textbook highlights that horrifying statistic. 30% of ruptured AAA cases are misdiagnosed on the first pass, most commonly as renal colic, kidney stones.
It's terrifying. But the retroperitoneal anatomy explains the misdiagnosis perfectly.
The aorta runs right along the spine in the retroperitoneal space, sitting directly adjacent to the kidneys and ureters.
Yeah, so when a AAA leaks or bursts, the expanding hematoma chemically and physically irritates the exact same retroperitoneal nerve pathways as a passing kidney stone.
So the patient feels intense flank and back pain.
Exactly. And if you assume it's a stone and send them to the waiting room for a CT scan, they will bleed to death internally.
Which is why the textbook rule is unbending. If you have an elderly patient who is hypotensive and they complain of pain anywhere in the abdomen, the back, the flank, or the groin.
It is a ruptured AAA until definitively proven otherwise. You reach for the bedside ultrasound immediately.
Right. And what about an upper aortic dissection?
Well, that's where the inner lining of the aorta in the chest tears and high-pressure blood tracks between the vessel layers. The physical exam offers a massive, instantaneous red flag here.
You check the blood pressure in both arms?
Yes. Finding a differential of greater than 20 millimeters of mercury between the left and the right arm means you must assume the aorta is dissecting.
Because if that tear propagates up the aortic arch, the false lumen fills with blood and physically occludes the opening of the subclavian artery feeding one of the arms, right?
Exactly. So one arm gets full, bounding arterial pressure, and the other gets a weak trickle.
A simple blood pressure cuff reveals a catastrophic internal tear.
Incredible. So the vascular system is a classic macro emergency, but the ED filter applies just as ruthlessly to highly localized plumbing and wiring.
Right, moving to genitourinary and neurological do-not-miss diagnoses. Delayed recognition here leads to permanent organ loss. Let's start with penile disorders.
Differentiating phimosis from paraphimosis in an uncircumcised male.
The definitions sound similar, but the mechanical outcomes are vastly different. Phimosis is a non-retractable foreskin. It's stuck closed over the glands.
Right. And paraphimosis is when the foreskin is retracted, swollen, and trapped behind the glands.
So one is stuck forward, one is stuck backward. Why is the one stuck backward a drop-everything urologic emergency?
Because it creates a localized compartment syndrome. The foreskin trapped behind the glands acts like a rubber tourniquet.
Oh, I see.
Arterial blood pumping into the glands is under high pressure from the heart, so it easily pushes past the tight band. But venous blood draining out of the glands is under very low pressure.
So it gets choked off.
Exactly. Blood continuously pools, massive edema ensues, and within hours, the tissue becomes fully ischemic and will necrose.
Wow. So the initial treatment is manual reduction. You apply steady circumferential compression to the glands for several minutes to physically squeeze the edematous fluid out, making it smaller.
Right. Then push the glands posterior with your thumbs while pulling the foreskin forward with your fingers.
And if the tourniquet is too tight and manual reduction fails,
You have to do a surgical dorsal slit procedure to physically cut the constricting band of skin.
got it.
Also, as a related clinical pearl, if you see balanoposthitis, inflammation of the glands, and foreskin, the PEX notes, it can be the first presenting sign of undiagnosed diabetes mellitus.
Really? Because high systemic blood glucose means the urine is full of sugar.
Exactly. It creates a perfect, nutrient-rich feeding ground for fungal and bacterial infections in that localized mucosal tissue.
Makes total sense. Okay, another critical urologic emergency driven by ischemia is testicular torsion, where the spermatic cord twists, cutting off the arterial blood supply.
Right. And you are looking for the bell clapper deformity on exam. Because the cord has twisted and shortened, the testicle no longer hangs vertically. It sits abnormally high in the scrotum and aligns horizontally.
And to confirm that ischemic theory, you check the cremaster reflex.
Right. You lightly stroke the inner thigh, and the cremaster muscle normally contracts, elevating the testicle. In a true torsion, the nerve and muscle are compromised by the twist, so that reflex is completely absent.
Furthermore, moving or manually elevating the testicle doesn't relieve the pain, right?
No, because the pain isn't from a localized bruise or strain. It's ischemic pain. The tissue is starving for oxygen at the cellular level.
Which brings us to our final filter, neurology. Specifically, the complaint of dizziness. It's incredibly common and notoriously difficult to nail down in the ED.
Oh, absolutely. Is the room spinning because the inner ear is confused or because the cerebellum is actively having a stroke?
What's fascinating here is how you separate the two. We rely on highly specific physical maneuvers to differentiate peripheral inner ear issues from central brain issues.
The classic diagnostic tool is the Dix-Hallpike test for benign paroxysmal positional vertigo, or BPPV.
Right. BPPV is caused by canalithiasis, literally tiny calcium debris or rocks floating in the endolymph fluid of the posterior semicircular canal.
So to perform the Dix-Hallpike, the patient sits on the bed. You turn their head 45 degrees to physically align that specific posterior canal with the plane of gravity.
Then you rapidly lay them supine, extending their necks slightly off the edge of the bed.
You are physically trying to make those microscopic calcium rocks tumble through the fluid.
And while they tumble, you stare directly at the patient's eyes. You are hunting for nystagmus, an involuntary rhythmic twitching.
But you don't just note that it's happening, you track the latency. It usually takes 5 to 10 seconds for the rocks to start moving and the twitching to begin.
You also track the duration, right? It should resolve within a minute as the rocks settle at the bottom of the canal.
Exactly. And you track the specific direction of the eye movement. If it follows that delayed, short-lived pattern, you've confirmed peripheral BPPV and ruled out a central stroke.
That filter mindset changes everything. So what does this all mean? We didn't just walk through a textbook today. We traced the mechanical logic of the emergency department.
Yeah, we started with the fluid dynamics of an IND and the spasm physiology of an ABG.
We zoomed out to the rigid, algorithmic ABCDEs where hypothermia destroys the clotting cascade, and we unpacked the mechanical failures of the heart in the 5Hs and 5Ts.
We used the cardiac cycle to calculate MAP, used that to distinguish ischemic strokes from encephalopathy, and learned to suspect a retroperitoneal aortic bleed every single time an elderly patient complains of a kidney stone.
And we finished with the tourniquet ischemia of paraphimosis and the tumbling calcium rocks of BPPV. It all reinforces that emergency medicine isn't just about memorizing facts, it's about algorithmic prioritization.
Right.
So, to test your retention, here's an interactive review question for you, the listener. You are evaluating a 72-year-old man in the ED. He has severe left flank pain, and the monitor shows his blood pressure is steadily dropping at 85/50. The triage nurse suspects a kidney stone. Based on what we unpacked today, what immediate life-threatening diagnosis must you rule out first, and what bedside imaging tool should you reach for right now?
Well, you have to think about that shared retroperitoneal anatomy.
Right. If you said you must rule out a ruptured abdominal aortic aneurysm and you immediately reach for a bedside ultrasound or fast exam, you're filtering exactly like an ED physician.
Absolutely. Looking back at the sheer amount of physiology we deduce just from touching the patient, it leaves us with an important question for anyone studying medicine today.
What's that?
As we get access to increasingly complex lab panels and incredibly high-resolution MRI scans, how do we ensure we don't lose the simple life-saving art of the physical exam? I mean, a CT scanner won't save a patient if you forget to feel for a cremasteric reflex, or if you neglect to simply put a blood pressure cuff on both arms.
Wow, that's so true. Keep your hands-on skills as sharp as your textbook knowledge, because when you step into the ED, you aren't quietly gathering puzzle pieces, you are running a filter.
And the physical exam is your best tool to catch the things that matter most.
Keep your eyes open, trust your algorithms, and we'll see you on the next deep dive.